Welcome to Brainthropology. Let's talk about our amazing brain and the issues that get us stuck. We all have those moments where life gets overwhelming. It can be related to injury or illness, or an issue with your kids, or just because life is crazy and we need a little help and encouragement. Our team of therapists, expert guests, and clients are here to deep dive into the topics that matter most. We will share information with our listeners that encourages, educates, and empowers.
This episode is brought to you by Galaxy Brain and Therapy Center, helping clients live their best lives by implementing strategies such as those discussed in this podcast. Galaxy Brain and Therapy Center is located in Ann Arbor, Michigan, serving southeastern Michigan for in-person and community-based services. Out-of-state virtual and teletherapy services available for OT, PT, speech, mental health, and mindfulness. Check out their website at galaxybraincenter.com.
Hello, everyone. Welcome to the Brainthropology podcast. We have an informative show today planned. We are so excited to have physical therapist Shelly Roller and Amanda Couch on with us today, and myself, Debbie Loftus, as today's host. So today we're talking about the vestibular system and vestibular rehabilitation. Before we get started, we always like to encourage people to start their day with gratitude. And one way that we do that is sharing a personal or professional positive. So mine is yesterday in Michigan in November. It was almost 70 degrees. So I love beautiful weather.
It was amazing.
It was. So
Yeah.
I got to go for an 11-mile bike ride, which was awesome. So that filled my cup up. What about you, Shelly?
I had a professional kind of win this week. I have a client who was in a pretty severe auto accident when she was 8 years old. She's 18 now. Started coming to see us about 5 or 6 weeks ago. When we started off for standing, she could only tolerate about 15 seconds. We got up to 2 minutes and 45 seconds last week. And we figured out that we had all the pieces for her standing wheelchair to go into standing. And she surprised me yesterday by coming out of her OT session fully standing. And then we did an additional 10 minutes of her like doing maneuvering in the wheelchair, which was awesome because she could only tolerate not even full standing last week, and could only tolerate about 2 minutes up. So it was very cool. Yeah.
That's a huge win in our community. Yeah. Like that is a huge win.
Yeah, it was very cool.
If we could give her a yellow big star sticker.
Yeah, it was the way I ended my day, and I said, you totally just made my week. So it was very cool.
That's incredible.
Yeah.
What about you, Amanda?
So mine is also professional. So I have my board certification in neurological physical therapy. That's something you have to renew like every 3 years. And it's like this super extensive like process to do that. And I just got an email this week that I'm good to go for another 3 years.
Oh, that's awesome.
Incredible.
So
it takes a lot of time and effort.
Yes.
You go, girl. All right, so let's dive in. Why don't we start by telling our listeners what the vestibular system is? So, Amanda, can you give kind of an overview of what the vestibular system is?
Absolutely. So the vestibular system is the portion of our balance system that provides sensory information about our motion, our equilibrium, spatial orientation. That information is provided by the vestibular apparatus, which is like the inner ear and the nerves that lead to the inner ear.
That's a fun word.
Yeah, I know. So in each ear, we have a utricle, saccule, and 3 semicircular canals. And each of those pieces of the inner ear gives us different information about our motion and where we are in space. So the vestibular system also, though, includes the portions of the brain that process information from that.
And that's the functional part.
And that's the functional part, yeah. Okay. So if we have breakdown in either the brain or the inner ear, we can have some issues that arise. So overall, our vestibular system, like its main job is just to tell us information about where we are. It tells us where upright is based on gravity. It also tells us the speed and direction of the way we're moving, of which direction we're turning our head. So it's this really cool fine-tuned system, but because it's so fine-tuned, there certainly can be issues that arise.
For sure. And for our listeners, if you want any review of the definitions that we're giving, because I know some of the words are pretty extensive in the different parts of the ears, you can go on vestibular.org and you can get some more information on that. All right. So now that we have an overview of the vestibular system, let's talk about some of the common things that happen when there's a problem with this system. That's more how it affects us and our listeners. So I know one common issue is vertigo. So can you tell us what vertigo is?
Absolutely. And I will say right now, it's a pet peeve of mine when people will diagnose someone with vertigo, because vertigo is a symptom.
Okay.
And what that symptom is it's that sensation that the room is kind of like spinning on you. I'm here talking with my hand. Yeah. But yeah, so it's the sensation that either the room is spinning or a really strong sense of like internal spinning. It's sometimes, most of the time, accompanied by something called nystagmus, which is like a repetitive movement of the eyes, and that's what gives you that sensation that the room appears to be spinning or bouncing. It happens when either there's like a major, I won't say major, but an issue with the inner ear itself, something's going on there, or somewhere in the brain that processes information from the inner ear, something's going on. Anytime either of those places are interrupted, we can have that sensation of vertigo.
So that's interesting because I know a few times in my life, whether it be family members or myself, I've had vertigo. I know sometimes people have complained of it after they get out of a cruise ship. Yeah. Or if they've been in an accident or had an injury. So, we work with people with brain injury, and many times that is from a car accident. And I know sometimes that jarring effect can affect some of those things in the inner ear. So we'll kind of dive into that a little bit more. So what is the difference between vertigo and dizziness?
That is a great question. So vertigo, again, is that symptom that is really specific to the sensation that either the room is spinning or that really like strong internal sense of you're feeling like you're spinning. Dizziness, I think of more like lightheadedness, wooziness. Sometimes people say dizziness when they're feeling pretty unsteady on their feet. So that would be more that like description of dizziness.
That has to be hard to kind of weed out the difference between the two when you see somebody.
Absolutely. Yeah. So a lot of times it's that description of how someone's experiencing those symptoms and how long and the when it happens and what triggers it that tells us a little bit more of what's going on with the inner ear of the brain.
So when you have an evaluation, you probably have to cue clients and ask them a lot of detailed questions.
Yes.
When they come in, because when they're just like, oh yeah, I have vertigo. I'm dizzy.
Yep. And it's like, oh, so you've been spinning. Oh, no, I'm not spinning. Mm-hmm. I feel really unsteady on my feet. Oh, okay. Yeah. So that kind of clues me in. Okay. Maybe it's not so much those issues specific to the inner ear, but maybe just, a gradual decline in function where we're having some balance issues, or maybe it is still inner ear related, but not to the point of causing that nystagmus and that vertigo. So it kind of gives us like really helpful hints of where to go next.
The history is really, really important in a vestibular evaluation. It gives us so much information, which people are like, oh, that probably doesn't mean much. I'm like, oh no, it really means a lot. Yeah. So the more information, the better.
That's super important. And so there is a word that we're going to be talking about next, and I'm not going to say it because I will totally butcher it, but it's called BPPV, and it's really interesting. I'm excited for the listeners to hear about it. Shelley, do you want to go ahead and describe that for me?
So BPPV is a fancy word, or it's an acronym for what's called benign paroxysmal positional vertigo.
Say that again.
Benign paroxysmal positional vertigo. And yes, I had to practice that many times when I was learning about this. But it's a very common inner ear disorder. With BPPV, or the benign positional positional vertigo, the changes in your head position, such as like tipping your head, backwards, rolling over in bed, sometimes going from sitting or laying down to sitting up, it can lead to a sudden vertigo or that spinning of the room, or that feeling of the intense spinning inside of you. It is usually very short-lived, usually about a minute. But it is caused because these crystals that are supposed to be in your inner ear, but they become dislodged, and they go in those semicircular canals that Amanda had mentioned earlier, and it disrupts the fluid flow in the inner ear, which is it's all supposed to be there. But when those crystals come in, it's like kind of like, I like to describe it as like pebbles in a river. So instead of having a nice flow, you've got those little currents that are created. Well, that gives some false information to the brain, and then you have that feeling of that dizziness that will happen. Other symptoms can also be included with this, and some of those are that feeling of unsteadiness. Nausea can sometimes be included, blurred vision, and again, that nystagmus that Amanda had mentioned earlier.
So the nystagmus has always interested me because for our listeners, when we do an evaluation, and these women are way more educated on this than I am, but you actually can look for eye movements, right?
Mm-hmm. Yeah.
And is it upbeat, down? Like there's different categories of how they look for it. Tell me a little bit about it.
Direction of the movement of the eye in certain testing positions actually tells us there's 3 semicircular canals. So the direction actually tells us which canal is involved, and so which treatment needs to be performed. Because the BPPV is like a mechanical issue of the inner ear, like Shelley was saying. It's those rocks or crystals, however you want to describe them. They're in a place where they don't belong, and the treatment is actually to use gravity to move them back to where they do belong, which is kind of crazy.
So I've been on the other side. I've been treated for this, and I find it so fascinating for listeners. If you've had it or you haven't, or you haven't been given the treatment, and Shelley is going to go into vestibular rehabilitation therapy, but you're actually maneuvering the head. So if our listeners can kind of picture laying on a table and having a therapist cradle your head and positioning your head in different orientations. And the way that I was described to it when it was happening to me is those little mazes. It's like, okay, the correct position of your ear is over here and this one isn't. So you have to get the ball or your crystals back around a maze into the appropriate position. And the good thing about BPPV is it's so treatable.
Very treatable.
Sometimes in one session, people come out and they're like, oh my goodness, this is so functional for me, because they came in and they were holding walls and they were holding tables because they felt like they were going to fall. After this maneuver, they got up and they didn't feel woozy. Everything was in the right place. And I know there's different things you have to do to try to keep it there for a certain period of time, but we'll go into the vestibular rehabilitation part now. So Shelley, why don't you go ahead and tell us what vestibular rehab therapy is, or VRT as sometimes it's called.
Yeah, VRT is really a combination of a bunch of things that we put together. It's a type of therapy that helps to address the feeling of dizziness or unsteadiness that is associated with vestibular issues. These can be done through different types of exercises, such as balance exercises. Sometimes we incorporate head movement, eye movements. We also do education of the clients on safe ways to maneuver in their environment, just to make sure that that's going to be safe for them to move around.
So after those maneuvers, is there a certain recommendation how to keep the crystals there?
So there's some research that it's a little bit... It's a little bit controversial. There used to be a very much a protocol with, yes, you couldn't lay down for like 24 hours. You had to sit up. You shouldn't be turning over and laying over on your bed. Some of that's kind of gone away now. I typically don't tell my patients to do a lot. I just, kind of keep an eye on it, because sometimes we don't get all of the crystals right away, so we might have to repeat the maneuvers. You can also feel a little bit off even after that therapy, because you have been living with this sort of fluid disruption, and your body is so amazing. It's trying to adapt to that.
So your vision system has to catch up.
Vision, the brain, everything sort of has to kind of realign again. And so you might just feel a little bit off for a day or two just because it's working normally again. So I always tell my clients that, give it a couple days. It's not any better. I can always recheck you. And sometimes it's hard to see that, like when we do those maneuvers, it's really hard to see that nystagmus. So sometimes we have to put special lenses on people to take away the vision. And so we can just see their eyes and see how they do it. And we record it, and then we can play it back and say, oh yeah, look, that's still kind of beating around there, and it's moving in a certain direction. So, instead of this canal, we might need to look at this canal instead.
That is so fascinating, Shelley. Can you tell us what those lenses are called?
They're called Frenzel lenses. They use infrared lighting, so we can still see the eyes, even though the patient or the client will feel like they're in the dark. So it's a pretty cool tool. It allows us to see their eyes without them fixating on something, and allows a much more natural movement of the eyes during the movement.
Oh, that's so neat. So why would your crystals become dislodged? So we talked about an accident, and I think I read once that it also can happen because of age, that there's like a sticky substance that maybe becomes less sticky over time. And that's a terrible analogy, but could you elaborate on that?
Yeah, so the aging one specifically, so the membrane that those crystals are meant to sit on. So we're supposed to have these crystals. Shelley mentioned that earlier. They're a really good thing. They sit on this membrane and kind of slide back and forth. They are what tells us which way is upright based on gravity. As we age, that membrane can become a little less sticky and jello-like, and those crystals, the actual quality of the crystals, it's a similar structure to bone, not too terribly different. As we age, sometimes the quality of our bones change. Quality of those crystals and their ability to stick also changes. So that's, more specifically the aging one.
So it can just happen because of aging. It doesn't have to be an injury.
It becomes more common, unfortunately. Yeah. And then the other thing is once you've had it once, it's very likely you will have it again at some point in your life.
That's terrible.
But I think knowing what it is and knowing it can be treated.
And so quickly, too.
And so quickly, and you can get really fairly quickly is really important. It's the people that haven't quite figured out what it is and are kind of just living with it for like periods of time that I really feel for, because it's like they don't know something can be done, and there are a lot of people out there, unfortunately, that's the case.
Yeah. And your therapist can teach you a maneuver you can do honestly at home that a lot of times can correct it. So once you recognize like this is the same feeling I'm having over and over again, it's exactly the same as it was before, you can do this maneuver and usually take care of it, which is a really, really nice thing for the person to have.
Well, that's promising. So as I've said before, I've had the pleasure of being a recipient of vestibular rehab. And I think it would be so cool for the listeners to hear what a session might look like. So I was so surprised when I was in therapy that it was so interesting how many systems that were challenged at the same time. So like my balance and my vision were being challenged at the same time to desensitize my vestibular system. And I was so educated by the time I left at how the brain works, with your body and how these systems are challenged. Can you kind of give me what maybe a typical, I guess they're so individualized, not necessarily typical, but what a session might look like with vestibular rehab?
There really isn't a very typical session once we get into it. I do tend to give my clients a home program. So there's some couple things that I always have them do that research has shown that has been very beneficial for them. But especially as they are progressing and getting a little bit better, I like to make things really, really challenging. So I might have somebody standing on a piece of foam and I have them hold 2 cards off to the side, and they have to quickly move their eyes back and forth while they're saying the words that are on the cards. And then once they've done the activity, I'll take the card away and say, okay, what words were on there? So you've got the cognition that's kind of a memory that's being put in there. You've got that eye movement that sometimes triggers the vestibular system or the symptoms with that. And you're working on the balance as well, because by standing on a soft surface, you're taking that proprioceptive input, which is one really key part of balance, away. So you're really challenging that vestibular system.
That's so interesting. And then from an OT perspective, we always go with the function, right? So in my head, I'm like, okay, so the reason you're doing that is because out in the real world, if you're driving and you're passing signs that you have to read, you're moving and you're trying to look at a stationary object. So there is a ton of implications with when your vestibular system is impacted.
One of my favorite things that I like to do with clients is have them simply walk and look around, so which I think when you have dizziness or you're feeling unsteady, you tend to look at the ground in front of you, don't move your head, and you concentrate just on that walking. Well, who does that in real life? Sorry.
Yeah.
So one great example is at the grocery store. What are you doing when you're at the grocery store? You're going down an aisle that has cabinets on both sides, and you're looking and you're scanning and you're looking to try to figure out where that item is at, especially if it's not an item that you buy an awful lot and you have to figure out where it's at in the store.
Right.
And so that's a lot of head movement. That's a lot of that eye scanning. That's your balance. You have to figure out, oh, this person's coming at me with a cart. So you have to be aware of those surroundings. So that's one thing, like when they say, why am I doing this? This is kind of silly. I would never just walk around and like turn my head side to side. And I'm like, well, this is why. Exactly. So let's try to apply it to real life.
Oh, that's so important. So can you explain to the listeners who needs VRT? So, when somebody comes to the clinic, what are the typical reasons why they would need it?
If really anyone who's having difficulty with balance or feeling dizzy or unsteadiness might be beneficial, or it might be beneficial for them to have VRT. During their evaluation, we look at not only their balance, but we look at their oculomotor system. So we look and see how their vision or their eyes are moving in certain patterns. If they become symptomatic with some of those movements, then they are likely going to be required to have the VRT. If you've been diagnosed with that BPPV or any other inner ear issue by an ENT or an audiologist, then VRT is probably very indicative for you as well. You talked about getting off a cruise ship. Mm-hmm. That's an actual real thing. It's called maldisembarkment syndrome. I think I'm saying that right, but yeah, and that's something that we can address for them as well. And then anyone who's had a concussion or a brain injury or really any neurological event would likely benefit from some sort of VRT as well.
Oh, that's awesome. So talking about, the vestibular system, and we talked about dizziness, and that's probably one of the most common when it comes to vestibular that I hear is, clients say, hey, I'm dizzy. What do I do next? So what would be the next step if somebody is having these symptoms that you've been talking about?
Absolutely. So I think the first place to start is your primary care physician and letting them know that your dizziness is, how it's impacting your life. And I would say be an advocate for yourself in this, because dizziness is a pretty common complaint. And sometimes it's just swept under the rug unintentionally. But I would say very much, start with your primary care physician. They may refer you to an ENT. But they could also actually just refer you directly to a vestibular rehabilitation therapist. I know at Galaxy, we very much love to see you. And that VRT therapist is actually going to be able to kind of direct you if you do need to go somewhere next, of like, oh, no, you really do need to go see ENT. You really do need to see like neurology next.
So that's an important thing to ask is, do you have somebody that specializes in this? Because not all therapy clinics have it, correct?
Yeah. So when you are talking to a physical therapy clinic, I would ask if there is someone there that specializes in it and what their training is and how often they're seeing it. I think that's the big difference. Like the actual exercises, there's no special sauce to them. It's understanding the different conditions and being able to progress those exercises appropriately and to understand which each condition, where you're going to find those deficits. I think that's the big difference with being, a little bit more skilled in vestibular therapy.
Awesome. So visit your PCP, and then, as far as, is it a certain period of time before you should go? So I know, a few cases of vertigo when you should seek emergency care. What would that entail? Yeah.
So I would say whenever it's spontaneous, and you're sitting still and it comes on suddenly. It's not happening with movement. It's staying. It's longer than 30 minutes. The room is truly spinning longer than 30 minutes. Like I said, it's not triggered by movement. It seems to be just always there. And if it's accompanied by anything like difficulty speaking, weakness, or confusion, for sure. And this is one that's actually near and dear to my heart. My dad had an episode of vertigo, which was the diagnosis given to him by his primary care physician. And he was just sent home to wait it out. It turned out to be a cerebellar stroke.
Oh my goodness.
So 2 days at home before he finally went to the hospital when he started to develop that motor weakness. And my mom, a nurse, was like, hey, this is not okay. So I would say in those cases when it's really constant, that is time to go get that emergency care.
Yeah, that's really important. And I know sometimes things will be prescribed to help with it, and sometimes it masks it, right? What's a common, I can't remember the name of the...
Meclizine.
Meclizine, yeah.
Okay. Yeah, and sometimes that can help, but it's putting a Band-Aid on something that needs a different fix.
And if they are on it, we actually, I try to ask my clients if they are on anything, because I would prefer them not to be on it during our therapy sessions for that very reason. We try to prescribe these exercises at a specific rate, and a lot of it is based on their symptoms. And so if these symptoms are masked, then we don't really have any idea of how they are reacting to it. So if they, let's say, run out of meclizine, or they decided not to take it, and then they do these exercises at home at the rate that we thought was going to be good for them, it can actually make it much worse. So it's a kind of a fine tightrope walk that we do, saying, yeah, this is the correct number for you to do to get better, but we don't want to go too far, because then we can kind of push it into an area we don't want to go to.
Absolutely. And it's a vestibular suppressant. It suppresses information from the inner ear. So when we're trying to retrain the brain of how to use information from the inner ear, not the most helpful thing to suppress all that information. You know, good for like really early on symptom management when things are really truly not, pleasant and fun. But yeah, once we get into the VRT, not necessarily a super helpful thing to have on board.
Yeah. That's great information. So we also have some resources that we will list in the notes of the podcast, one of which is the vestibular.org website. And also for BPPV, is it dizzyandbalance.com?
Yeah, dizzyandbalance.com had a really good explanation of what BPPV was and how they treat it, and kind of had a good diagram of what the semicircular canals and the inner ear looks like.
Excellent. Wow. Thank you, ladies. That is a ton of information about vestibular rehab. You've answered a lot of questions. So let's review some of the important points that we went over today. We learned that the vestibular system is the portion of the balance system that provides sensory information about motion, equilibrium, and spatial orientation. We learned that vertigo is a symptom of having an issue with the vestibular system, and it describes the sensation that a room is spinning, or a very strong sense of internal spinning. And it's typically accompanied by something that we described as nystagmus, or repetitive motion of that rapid eye movement. We learned that BPPV is a common inner ear disorder, and it changes changes your head position, such as tipping your head backward or rolling or sitting up in bed. And it's when that change leads to sudden vertigo. So that feeling that the room is spinning. And it's caused by those crystals that we talked about that become loose in the inner ear and disrupt the fluid flow in the semicircular canal, which then sends a false signal to the brain that causes symptoms. And then the last thing we talked about was about vestibular rehabilitation therapy, or VRT, and that it's a type of therapy that helps to address the feeling of dizziness or unsteadiness that's associated with vestibular issues. So we hope that you enjoyed today's podcast. Please see the show notes for some great links and resources about today's topic. If you found it helpful, or you think that any of your friends or family would benefit from hearing it, please share this episode, and feel free to check out other episodes at brainthropology.com. As always, we encourage you to be courageous and move forward in your day with hope, joy, and purpose.
While we love what we do and are as passionate as they come, the information on this podcast and discussion is for educational purposes only and should not replace professional medical advice. Please consult your own healthcare provider if you are seeking medical advice, diagnoses, or treatment for you or anyone else. We do our very best to provide correct information, but please understand science and medicine is ever-changing. We welcome feedback, comments, suggestions, or correction of errors. This disclaimer applies to any guest or contributors to the podcast or blog.